The next topic is going to focus on everyone's most hated kind of medication in this disease and what really stands out in AIH as kind of antiquated approach to treatment of autoimmunity is our dependency on corticosteroids. And again, you've heard it time and time again today. Just too many patients are requiring anywhere from low to moderate dose of corticosteroids, beyond the first year into subsequent years, and upwards of 30 to 40%, depending on what database you look at. So I'm actually pleased to introduce Dr. Yara Sarkis. One of our missions here at the AIHA is to include young investigators and trainees, and Dr. Sarkis is actually finishing her residency in internal medicine here at IU. She's been a shining star in terms of the research with our divisional research outside of even the liver disease. So someone no better to talk about steroids and someone that's closer to internal medicine than I am is Dr. Sarkis. So thank you, and will you join me in welcoming her?
Okay. Hi, everyone. Like he said, I'm Yara. I'm a third-year resident at IU. I have the pleasure today to talk to you about steroids. Thank you, Dr. Lammert, for this opportunity. I mean, it's a lot for me, so thanks. So the goal today is to talk about the risk of long-term steroids, and my goal is for you to, leave this lecture with this in mind. Long-term steroids are not the answer, and we're going to work, through this presentation together. So I'm going to start by talking and giving you some data insights, and then talking a little bit about how steroids work and what they do in our body, then shedding some light about side effects of long-term budesonide and prednisone, and giving you an alternative. So some data here. I took that from the Autoimmune Hepatitis Association website. Basically, 120 patients were enrolled in that survey, and the average age was 55 years old. And it turns out that 53% of those patients were taking steroids. Another data that I also pulled out is showing here that through the years, even until like 15 years, patients are still on prednisone or budesonide, and the frequency of that is very, it's a lot. So then we have budesonide between 11 and 20% of patients are on budesonide for a year or even more than 15 years, and prednisone are at the rate of 20 to 40% as well. Another study called the GRACE study is actually looking at patients between IU, UPenn, Mayo, through social media, and also through our last year's conferences. And it basically looked at patient perspective for the disease. One of the questions was, how would you prioritize autoimmune hepatitis research team during the next 10 years? And most of the patients wanted to get more insight about the treatment at 23%. And when we asked more specifically, how would you prioritize the treatment studies, 33% wanted to eliminate steroids. And this is my goal here today. So now what about you? I think if you have the application, if you can answer some of the questions I have. The first question is, are you on prednisone? And I don't know what the number is here, but do you have yours? Dr. Lemon, do you have yours? I couldn't get the number. Oh, okay, it worked. So okay, let me give you a second here. Okay, so most of you guys are not on prednisone. Congrats. And if you are on prednisone, most of you are on more than 5 milligrams of prednisone, and for more than 1 year. For the budesonide, also, most of you are not on budesonide, and if you are on it for more than 1 year. Thank you for answering. So how do steroids work? Prednisone actually becomes prednisolone in the liver, and this is the active ingredient of prednisone that actively work on the inflammatory and autoimmune diseases. Budesonide, on the other hand, it has more of a topical anti-inflammatory effect, and I'll show you that in the next slide. And hence, because it's more topical, it has less systemic side effects. And it was first tested in autoimmune hepatitis patients about 20 years ago, and was shown to have improvement of liver inflammatory activity without showing the same side effects or less side effects than steroids. But budesonide is contraindicated in patients with cirrhosis. So technically, when you take your oral steroids, prednisone or budesonide, you swallow it, it goes to your bowel here, and then from your bowel, it got absorbed to the liver. And around the liver, you have something we call the first pass metabolism, where this prednisone becomes prednisolone, and all the inactive part of it is just degraded. And so all the prednisolone doesn't only act on the liver, but also is absorbed through the blood to the systemic circulation and goes and touch all the other organs. And this is how you have the side effects that you have. Budesonide, on the other hand, is absorbed, work on the intestine, and then is absorbed to the liver. But in the liver, more than 90% of it is actually degraded. And only 10% of active budesonide goes through the systemic circulation and give you side effects. And this is why it has less side effects than prednisone. So steroids in autoimmune hepatitis are used both for induction and maintenance. So high-dose budesonide or prednisone with or without azathioprine is used as induction. And then for maintenance therapy, once remission is achieved, we try to individualize the low-dose therapy. And adding azathioprine showed to decrease prednisone dose and reduce the specific side effects, and we'll touch base about that a little bit in a bit. So the goal of this slide is basically to show you that most patients require lifelong maintenance immunosuppressive therapy, and we're trying to limit the use of prednisone. So what are the side effects of steroids? This figure is showing all the side effects of steroid, and please don't be afraid. Around the face, we can see something we call the moon facies, so like swelling of the face, some eye problem, cataract, glaucoma, insomnia, mood disorder. We also have a hump in the back called the buffalo hump, some acne, erythema, also skin atrophy, obesity around the trunk, a poor wound healing, myopathy, so muscle weakness, and then also bone weakness and fracture, osteoporosis. And then and more so like things that we don't really see, we have hypertension, so high blood pressure. We do also have increased susceptibility to infection because the suppressive immunity is decreased. We also have dysregulation in our blood sugar, so we can have diabetes. And we can have something we call adrenal insufficiency, and I'll talk a little bit about it in a bit. This graph, it's a lot of statistic jargon, but basically if you look at the graph, everything that's at the right of the vertical line means that there's an association between what we're studying. So in this graph, we're looking at cataract and prednisone and budesonide, and it showed that budesonide as well as prednisone more than 5 milligram is associated to cataract. Same goes for fracture, budesonide, and any dose of prednisone was associated to fracture, but diabetes, prednisone more than 5 milligram was associated to diabetes. Budesonide, on the other hand, is crossing that vertical line and is not associated with diabetes. That's another data or study that I found, but this basically look at budesonide and prednisone in a rheumatoid arthritis patient. So those are patients who have immune disorder of the joint, and they also need to rely on glucocorticoid a lot. And they're saying in this study that glucocorticoid dose as low as 5 milligram can cause infection and hospitalization for infection. Like you can see, all those data points are at the right of the vertical line. So all this weight gain, diabetes, hypertension, the mood disorder, the psychosis, are they really frequent? Well, yes, and they happen at 80% of patients after 2 years of treatment. And this is why it's really important to bear that in mind. When we combine prednisone with azathioprine, so when we decrease the dose of prednisone, those cosmetic side effects and those side effects that we can see and that are steroid specific have been found in less frequency. So more so, it's not only bothersome and it's not only, okay, pay attention, there's side effects, but also because of those side effects, especially the cosmetic changes, are the reason that patients stop taking treatment for autoimmune hepatitis. So it's very important to keep in mind that we need alternative. Budesonide is also associated with nausea, vomiting, and the same cosmetic changes, but like I said, it has a low bioavailability, so the side effects occur at a lower rate, but they do still occur. In that study, we see also, again and again, talking about adverse events related to the low-dose corticosteroid. And they started this study and showed that a steroid-specific side effect happened at a dose more than 7, that occur on doses more than 7.5 to 10 milligram per day. And then it's very important to reduce the dose below that threshold. But then when they continued their study, they demonstrated that low-dose prednisolone and budesonide are also associated with fractures, especially vertebral fracture. And budesonide as well increased cataract, but did not have an effect on diabetes like we mentioned a few slides ago. All of this to say that there is no safe low dose of steroids on the long term. This table just emphasized the same, a lot of statistic jargon again, but basically showing that prednisone have an effect on cataract, diabetes, and bone fracture. Budesonide only have on cataract and bone fracture. And the way I see that is because this number here is less than 0.5 when it's actually significant, but more than 0.5 for that. You don't really need to know all that, but just, you know. So what about, this adrenal insufficiency I talked about a little bit. So the adrenal gland is a gland that's above our kidneys, and it's responsible of actually secreting the steroids in our body, so the hormone that we have in our body. And steroids is very important for us to regulate against stress, and try to balance every hormone in our body. When we start taking prednisone from outside the body, this gland say, oh, okay, well, I have a lot of steroids. I don't need to do any more, or synthesize any more steroid. So it just shuts down. And the longer we're on steroids, the longer this gland goes to sleep. And we don't really feel the effect except when we stop the steroid or when we go through like a surgery or an infection and we need excess hormone and stress hormone from our body, and this gland is sleeping, and she goes, oh, no, I'm not doing anything. So this is when we start feeling fatigue, lethargy, low mood, weight loss, and muscle weakness. And we don't really test for it. It's not like you're going to go to your PCP or your hepatologist and be like, make sure I don't have adrenal insufficiency, because you're taking prednisone. But it's important to know, because once we want to stop the prednisone, we need to taper it down. So we can't stop it just point blank. As we go down and taper it down, the gland starts to wake up again. Same goes if we're going through a surgery or a very big infection or anything. We have to think about increasing the dose of steroid that we have and we take at home. Now, let's talk a little bit about fracture, and I'm glad with the preventative talk we had a few hours ago, we touched base on that as well. So prednisone and budesonide both reduce the bone mineral density, so decreases the strength of our bone, and so they can lead to fracture. And the most common fracture is the vertebral fracture. This is why we do need to do a bone mineral densitometry at baseline and then every 2 to 3 years. And we recommend people who are on prednisone, a patient who are on prednisone, to take calcium and vitamin D at the same time. What about the weight gain, and why is that important? So prednisone gives you this truncal obesity, gives you this hump, swelling in the face, and why do we care? Well, weight gain is actually contributing to the obesity pandemic, and so we need to have a healthy lifestyle while on steroids. And thanks for the talk we had also around noon about what's the healthy lifestyle for that. But then when we have weight gain and we get into the obesity, the problem is that we're going to develop something we call metabolic associated steatotic liver disease, and Dr. Samala just touched base on that. So basically, weight gain and diabetes gets you to accumulate all this fat in your liver, and then you might develop MASLD. And so you have new abnormal liver tests, and is that relapse, or is that because of your MASLD? And this is where we start, like hepatologists and experts start to struggle. Should we increase the prednisone, or should we do a biopsy, or should we just change lifestyle? And how do we determine, what's the cause of this abnormal liver test? So I told you all about why not steroid, but what is the alternative? So the steroid-free treatment survival treatment we have is azathioprine. Basically, it's the first drug of choice for maintenance therapy in autoimmune hepatitis. I didn't ask this question on the poll, but who is on azathioprine in this room? Okay, great. Thanks. So it was introduced, we need to introduce it 2 to 4 weeks after initiation of the steroid treatment, and we start at a low dose, and then we increase gradually. And studies have shown that maintenance therapy with azathioprine alone is not associated with relapse, and it's equivalent, the outcomes are equivalent between prednisone and azathioprine versus azathioprine alone. And so tapering steroid should occur as soon as maintenance therapy is initiated because eventually we're going to have the same benefit with less side effects. That's another study that shows that there is no statistical difference in outcomes when prednisone was a part of the treatment regimen versus just using azathioprine. A lot of jargon as well, statistically. Another study here showed that a higher dose of azathioprine alone was successful in maintaining remission in 80% of patients based on laboratory, histological, and clinical finding. And so steroid-free therapy should be and can be a treatment goal in every autoimmune HEP patient to prevent steroid-related complication, and we should aim for it in the first year of treatment because, like I said, 80% of people on prednisone have those side effects at 2 years. But I'm not going to lie, azathioprine is a drug, and azathioprine does have some side effect. The prevalence of azathioprine intolerance is not really known, but the case reports have just shown it to be around 10 to 20%. And most side effects are basically gastrointestinal, so you have some nausea, you have some discomfort, but you can also have some more severe side effects like pancreatitis, arthralgia, which would just make you stop the azathioprine. And then the cosmetic side effects and many of the other side effects of corticosteroids are not seen. So this table actually summarizes most of the side effects of prednisolone, budesonide, and azathioprine and what we should do to avoid them and prevent them. I'm not going to go into all this detail. We talked about it a bit in my presentation and the other lectures, but also to keep in mind that azathioprine can give you non-melanoma skin cancer, and this is why we would need you to follow with your dermatologist or your PCP every year and make sure you don't have a new lesion. And so, to end my talk, I'm just going to say steroid-free treatment should be the mainstay of treatment in autoimmune hepatitis, and I encourage you all to talk with your hepatologist or PCP or whoever's treating you for it, and start considering alternative. Thank you.
Thank you, Yara. That was great. So, just to kick off, to share kind of my clinical perspective of this, I spend a lot of my time as a hepatologist trying to figure out how in the hell to get people off steroids. This is an incredibly challenging piece for patients that are hard to treat, control. A lot of my patients that come to me often have abnormal liver tests. They've had to be on prednisone or budesonide for years. How can we do this? And again, Dr. Sarkis alluded to some of these things, and some of the literature is kind of guiding us that maybe azathioprine is underdosed, so you can check dosing of azathioprine. You can look at your CellCept dose, and maybe it's underdosed as well. Another area that's unexplored is about stacking therapies, using combination therapy of CellCept and Prograf or azathioprine plus one of those may be a strategy as well. Another interesting point that I think is when we diagnose AIH, trying to figure out ways that we can actually treat this disease without using steroids up front. Now, is that always possible if your bilirubin's 7 and your liver tests are in the thousands? Probably not. But in terms of the patients with low liver tests, anywhere from 2 to 5 times upper limit normal, maybe this is a paradigm that should be explored. And then finally, clinical trials have never really attacked patients at diagnosis. And so looking for steroid alternatives may also be an approach that we should think about in the future as well. I want to open the floor to any questions at all for Dr. Sarkis.
Hi, thank you. The question I have is with the diabetes, does that diminish when you come off the steroids, or is that a permanent scar?
Sure. So steroid gives you something we call insulin resistance, and also with all the effect of weight gain, your body starts to resist the effect of insulin in your body. Once you stop the steroid, this effect can get better and improve. We can't say for sure that you can be resolved at all, but it will get better when you stop the steroid. And we can see it on the diabetic population per se. People come in with their level of sugar that are always controlled, and then they take prednisone and they suddenly shoot out. And then when they stop it, they go back to their normal levels. Sure.
Has there been patients that was given prednisone and budesonide at the same time and still have issues with flare-ups?
Sure. There's no very much utility of combining budesonide with prednisone because it's the same mechanism of action. The only difference is budesonide is more localized to the intestine and the liver. The only goal of us combining treatment is either to decrease the dose of one of the treatments of prednisone, or, so this is why we added with azathioprine or other things, or to do any synergistic effect. But because it's the same class of medication, it will not change any of the outcomes, per se.
And since we're talking about budesonide, can we just, by a show of hands, you don't have to tell me if you've taken budesonide, has anybody experienced side effects from budesonide? There's a few. I will say I see this more and more. I probably wasn't a firm believer maybe 3 to 5 years ago. The biggest thing I see is actually easy bruisability. And this is a little bit of a change, particularly in budesonide in patients that have active inflammation, abnormal liver tests. The way budesonide is metabolized, it's probably becoming more systemic than we actually know, meaning it's not being cleared by the liver. You're getting systemic steroids potentially, just by the way it's metabolized. So it's something to consider. We always kind of said budesonide is fairly innocuous, right, because of this mechanism. It's probably not. So again, bone fracture and cataracts, this is not an easy way out of this disease in terms of treatment or treatment augmentation.
Actually, on the budesonide, so I was on prednisone for about a year, had all the things that you listed up there and then some, and finally asked my doctor if I could do an alternate, and I had read about budesonide, but I had presented with cirrhosis early on. He never has said it was, I asked him if it's okay. He said, sure. He's put me on budesonide for now the past year. It's been significantly better, so I'm just curious, what is the reason for not putting, he's never been concerned about cirrhosis and budesonide.
So basically, like, if I don't even remember the first figure where I showed you, the first pass in the liver of the budesonide, when the liver is sick, this first pass is basically abolished. So I think that it's contraindicated because we're just concerned that when the budesonide is going to build up in your body, it's going to give you side effects and complication. This is like one of the easiest way to understand why it's contraindicated in cirrhosis. And there was like some side effect where you have thrombosis because of it, and other things that were shown in the research.
Yep. So definitely both of those. In that thrombosis that she just mentioned, there were a few events in the clinical trial. And so the idea was that related to budesonide or the cirrhosis. The problem with cirrhosis is that we have, with years of cirrhosis, there is an inherent risk of developing blood clot in the portal vein because of slowed blood flow through the liver. So again, generally speaking, in our guidelines suggest budesonide just should not be used with cirrhosis. One other important point, what the literature has said about budesonide is, and I've seen budesonide used in patients with markedly abnormal liver tests. There is now a good data from, again, published this past year, when we wrote about it on our social media page, was that budesonide probably is ineffective when patients' liver tests are above 2 to 3 times upper limit normal. They definitely, compared to prednisone, it is not equally effective. So again, if I have a patient with a liver test more than 3 times upper limit normal, I almost never allow them to try budesonide. Again, they still may want to. They still may try, but we may have to augment with prednisone. There is something known as budesonide failure.
Okay. Perhaps this will sound like a very strange question, but has anyone considered like a topical application? And I'll say, in our own home, we have a cat. The cat has arthritis and is getting a prednisone, but instead of getting an oral prednisone, she gets prednisolone as a cream that we put in her ears. And so I would presume that that's not processed, by the digestive system. It would go through and do whatever good it needs to do. Anything like that for humans?
I don't think so. I know we use a lot of topical cream for like anti-inflammatory effect, but usually it's more localized. And if you put, I don't know, are you going to put it on the ear or on the liver, on the skin? It's going to have to go through the skin passage, and it's not going to have the same effect. It doesn't going to go to the liver the same way. So I don't think there's any application. I don't know if Dr. Lammert has any other thoughts.
And so there is a dose dependency piece to this, right? So, and again, systemic absorption. So again, the reason prednisolone works so well is the dose that's delivered to the liver into the cells in the liver itself. So I think that's the biggest barrier. Either way, no matter what, even if you dipped yourself in enough prednisone, I think you're going to get the side effects of prednisone. Fair enough. Maybe we could talk after. We're going to go into a break just to make sure you guys have time to restore yourself for 2 more talks, which are really important. We'll break and we have snacks over here. But thank you, Dr. Sarkis.